Thank you for joining us today. On behalf of Mammotome and our professional education department, we welcome you to a new series just for patients. Our first webinar is focused on screening mammography, and we recently spent some time with a panel of physicians, and they answered the most common patient questions. We also walk you through a screening mammogram, so you know exactly what to expect at your appointment. We hope you'll join us for the rest of our breast health series as we take a deeper dive into topics such as diagnostic imaging, biopsies, and surgical options for breast cancer. Please visit our education page at mammotome.com for more information on our upcoming webinars.
Hello, my name is Dr. Kimberly C. Hutcherson. I'm board-certified, fellowship-trained diagnostic radiologist specializing in breast imaging. I am the medical director of breast imaging at Northside Hospital Gwinnett in Lawrenceville, Georgia, and Northside Hospital Duluth in Duluth, Georgia, and an associate with North Metropolitan Radiology Associates.
Dr. Christine Ormsby. I'm currently practicing in Festus, Missouri, which is just outside St. Louis. I kind of rotate from site to site. Festus, Missouri is kind of a smaller hospital, so a lot of community-based, hands-on interaction with my patients, but I do get to do a little bit more interaction in the bigger city zone, so it's a good mix.
I'm Dr. Kang. I'm an interventional mammographer for a private practice group in Columbus, Ohio. My group's name is Radiology Incorporated. Prior to that, I did my residency training at The Ohio State University and also did my fellowship training in breast imaging there at the Stephanie Spielman.
Dr. Hutcherson, you are a physician, but you're also a cancer survivor. So what advice would you have for women who are afraid to have that first mammogram, especially during COVID times? Can you talk about what advice you would have for these women to really kind of encourage them to go ahead and schedule that first mammogram?
Well, as a breast doctor and a breast cancer survivor, I truly understand firsthand the importance of early detection. I tell women to not delay and get their screening mammograms now. I know during the time of early in the pandemic, breast centers were closed, but they are now reopened. We are taking all the precautions that are issued by the CDC for their safety, for our staff, as well as our patients that visit the center. So I really stress that if they were scheduled during that time to please come in now and return to their mammograms if they're scheduled now, please do not delay. A delay in your screening mammogram may lead to a more advanced stage of breast cancer, and we know that mammograms are mainly utilized to detect early changes of breast cancer when we have better options for treatment and better chance for cure.
One of the really kind of hot topics right now is screening mammography recommendations. So I think it causes a lot of patient confusion. They're hearing to start at different ages and maybe not go every year, go every other year, depending on the physician that they're talking to or where they're getting their information. So from your perspective as a radiologist, what would your advice be to a woman who is approaching screening mammography age?
So when it comes to screening guidelines from the radiology perspective, the American Board of Radiology, the Society of Breast Imaging, as well as the American Board of Breast Surgeons all agree that screening mammography should start at the age of 40 and should be done yearly. The reason that we all agree that it needs to be done at 40 rather than 50 is because there is a large group of women that can get breast cancer between the ages of 40 and 50 that would be missed otherwise. And given the young age that they have, the risk that they then have of getting that cancer and having it not treated appropriately for such a long period of time is really high if they're not caught until they're 50. The other reason that we say yearly is just because between 40 and 41 or 40 and 42, you can have a big amount of cancer increase. If you have something that is slow growing, it could grow over 2 years and become really apparent at the age of 42 and may not have been seen when you were 40, but when you come back yearly, it's much easier to catch these little things that are slow growing, or if you have something that developed in the interim, you're better able to catch that early on as well for treatment purposes.
If a patient is ready to start her screening mammograms, does she have to have an order in order to schedule that and come in for a mammogram?
No, orders are not required in order for a patient to have a screening mammogram. She's able to schedule on her own.
And so what would that process look like? So would they just call the breast center, or do they contact their local physician? Can you talk through and describe that process for a patient?
Sometimes it's facility dependent. At our facility, the patient's able to just call our breast center directly, and we actually have an online ordering process where the patients can actually go online and just schedule their screening mammogram through the online program. Every facility probably has a different process, but they do not need to go through their ordering doctor. They can if they'd like, but they do not need to go through their ordering doctor if they don't want to.
So Dr. Hutchison, one of the things that we hear most often from patients that might have some anxiety or fear of coming in for a mammogram is that they may have had a painful experience in the past, or they've heard from a friend or family member that may have had a painful experience. What would be your advice that you would give these patients?
The compression of a mammogram is necessary to obtain quality images so that I may see any abnormalities that may be on the mammogram. However, it is fast, it only lasts a few seconds, and the discomfort for most women is minimal. It's important to know that the increased compression is going to reduce the amount of radiation, but most importantly, it allows me to see any abnormalities that may be in the breast tissue and remove the overlying glandular tissue that may be obscuring it.
Okay, Dr. Kane, so if a woman is feeling something in her breasts or her underarm, or she's noticed changes in her breast, whether it's during COVID or really any time, can you give some advice to someone who maybe has noticed a change in their breast? What would their next steps be?
So if I were to have a patient come to me and tell me that they are feeling something new in their breast or in their axilla or armpit region, I would want them to definitely come in and be evaluated. That's regardless of whether or not we're in the middle of a pandemic or everything is back to normal. That's just, I think, one of those things where if you feel something new or you're concerned that something is changing within your breast or your armpit, you would like to get that evaluated, as soon as you can. So when we have someone typically come in with that complaint, if they're over the age of 30, and definitely if they're over the age of 40, we start with a screening mammogram. And then we follow that with a targeted ultrasound of the area that they have the complaint in. If they are under the age of 30, we will start with an ultrasound and then get a mammogram if it is necessary.
Sometimes after a screening mammogram, a patient may be asked to come back in for additional imaging. Can you talk about what it is that a radiologist may see on the mammogram to call them back in, and what those steps look like for a patient when they are back in for that appointment?
So there's several things that we might see on a mammogram that we may need to get more imaging for to get a better look at. One of the big things that we see that we may need to get more imaging for is basically a change from the prior year. So we're looking for early detection, so we're looking for any subtle changes that we need to work up more. Generally speaking, I'm looking for 4 things like masses, calcifications, architectural distortion, or asymmetries. Those are 4 things that I'm looking for that may have developed since the prior year, but overall, any change from last year's mammogram. The process is very similar. If we're starting with mammogram, we do specialized views, and for each patient, it may be a little bit different. We're going to do views that the radiologist would recommend that we need to see the area the best. So if we're looking for calcium deposits, we may magnify those areas to get a better look at those calcium deposits. If another patient has a small mass, we're going to do different views to get a better look at that mass. So each patient, depending on what we see, may have slightly different views that we're going to do. It all depends on what the radiologist needs to get a better look at it. If we need to, we may recommend an ultrasound after that. It depends on what we see on the mammogram, if we need an ultrasound to better characterize it. Sometimes we start with ultrasound, depending on what we see. Again, it's very patient dependent, and it all depends on what we see on that initial screening mammogram.
So you touched on using either mammography or ultrasound when a patient has a diagnostic appointment. Can you talk about the difference between those 2 modalities and how they help you as a radiologist see an area?
So if I have a screening mammogram and I see something abnormal, usually if I see something that looks more like a mass, I will go on to ultrasound. Ultrasound is very useful for helping us characterize masses. If I see something round on a mammogram and it looks like there may be something in the breast, I can't tell whether it's fluid filled or whether it's solid. That's where ultrasound comes in. It helps me tell what is making up that mass. If I see something more like calcifications, or if it's something more like an asymmetry just means there's something that looks different about the area of tissue, that's going to be better looked at with mammogram. And that's where we start with mammogram pictures to do more specialized views where we more focally compress that tissue out. We do more specialized mammogram pictures and push on that tissue to see what that area looks like. So depending on what that initial screening mammogram showed, will help us determine, do we need to look with ultrasound to see what an area is made of, or do we need to do more mammogram pictures to get a better look at what the area is characterized by?
Okay. What are some common misconceptions or myths about breast cancer?
Well, one myth is if you don't have a family history of breast cancer, I won't get it. But in fact, most women that are diagnosed with breast cancer have no family history. Most think breast cancer is an inherited disease. However, only about 5% of breast cancers are believed to be hereditary. That means that the vast majority of people who have breast cancer have no family history, but other factors are likely at work, such as environmental or lifestyle. The biggest risk factor for getting breast cancer is actually just being female, your gender, and getting older. Another myth that we can talk about is a myth. If you maintain a healthy weight, exercise regularly, eat healthy, and limit alcohol, you don't have to worry about the disease. And all of these behaviors are really important just to overall health and also just to lower your breast cancer risk. It can't eliminate it. It's really important to manage these things so you have a healthy lifestyle, but in managing what you eat, what you drink, your physical activity. But it's still important to get your regular screening mammograms and be aware of any changes that may occur in your breast. And notify your referring physician if you do so they can send you to the nearest breast center.
Great.
Another myth is wearing a bra, especially underwire, can cause breast cancer. There is no evidence that, that bras can cause cancer. I think it's all about the comfort. But myth, using underarm antiperspirant can cause breast cancer. But the safety antiperspirant is still being studied. There was some discussion at one point about aluminum within a deodorant that could cause the lymph nodes to be clogged and thus result in breast cancer, but that area is still being studied as not a fact. Myth, carrying your cell phone in your bra can cause breast cancer. In fact, there is no evidence that a cell phone can cause breast cancer when it's placed in the bra, but that's probably not the best place for that. So the safety of all cell phones actually is still being studied, but continue not to place it in your bra as a form of transportation. Myth, consuming too much sugar can cause breast cancer. In fact, there is no evidence that excessive amounts of sugar can cause breast cancer. It's not just really breast cancer, it's kind of all types of cancers. People have felt that the cancer would actually feed the tumor cells and cause them to grow faster. But in reality, cancer cells as well as healthy cells are going to use blood sugar or glucose as a fuel. Excessive amounts of, obviously the cancer cells are probably going to use more of these the sugar cells because they're more aggressive tumor type, but that doesn't mean that it causes it. But overall, excessive sugar can lead to overweight, and we know that's a known risk factor for developing breast cancer, so limit your amount of sugar intake just for your overall health. Annual mammograms guarantee that breast cancer will be found early. Although mammogram is the best early detection tool that we have, it does not mean that we're going to detect the changes early. As we know, breast density is one of the limiting factors associated with interpreting mammograms. So if you have dense breast tissue, we may not be able to see that early change of breast cancer at that time. But it doesn't mean, obviously most, doesn't mean that we're going to be able to see that breast cancer at that time. Most breast cancers are detected with mammography, so it's really important that we continue with our routine screening or annual screening mammograms to detect the early changes. However, make sure you're aware of breast changes, follow up with your clinician if you notice any changes, and get your examinations by your primary care provider as well. All of these combined will hopefully detect early changes of breast cancer. Myth, breast cancers always cause a lump you can feel. This is not true. Actually, the goal of mammograms are to detect changes before you can actually have clinical symptoms or feel a lump or palpable mass. But also many cancers do not present as a mass. They may present as calcifications or just an area of increased thickness within the breast tissue. So that's not a fact.
arrive for your mammogram, you will be asked to remove your clothing from the waist up only and put on a gown or robe that opens in the front. Make sure you have removed any deodorant, lotion, or powder from the breast and underarm areas. The technologist will discuss your current breast health and any concerns you may have. It's important to share any changes or findings in either your breasts or underarms so the technologist can identify these areas for the radiologist. You may be asked to complete a breast cancer risk assessment. This tool calculates a person's 5-year and lifetime risk for invasive breast cancer. The technologist may place a sticker on your skin to mark an area for the radiologist that may be a mole, scar, or even a lump that you are feeling. The top down, and the other is at an angle. The technologist will help you get into position, and it's important that you hold still during the x-ray. Your breast will be placed on the plate of the mammography unit, and a clear acrylic paddle will be lowered down to apply compression. Your breast is only in compression for a few seconds, and the paddle will lift up automatically as soon as the x-ray is finished. Make sure you talk to your technologist about how you are feeling during your exam so you can work together to get the best images. You may be offered either a 2D or 3D mammogram at your appointment. A 3D mammogram is also called tomosynthesis, and it captures multiple images of the breast in slices, much like the pages in a book or a loaf of bread. The positioning is exactly the same as a 2D mammogram, but during a 3D mammogram, the X-ray tube moves in an arc while obtaining your images. The technologist will verify that she has all the images and information the radiologist will need to read your mammogram. Some women require more than 4 images. This could be due to positioning, breast size, or if you have breast implants. You will receive your mammogram results by mail within 30 days, but usually it's much sooner. And your doctor will receive a radiology report. Some breast centers will provide results while you wait.